Also, this session is being recorded and will be on the center's website probably by tomorrow. So if you want to be able to see the recording of this, you're able to do that as well. So I am really pleased to be introducing Dr. Jean Abbott. She is a professor emerita in emergency medicine at University of Colorado Hospital Ethics Committee stalwart. She's been a member of the committee and a contributor to clinical ethics and academic ethics for many years here and around the community, really around the country. And so it's fabulous to have her. She's also on faculty at the Center for Bioethics and Humanities here. So again, she's going to be speaking with us on a very real topic about who gets the morphine, justice and suffering and medication allocation. She is also one of the major contributors to an article that is entitled Access to Therapeutic and Palliative Drugs in the Context of COVID-19, Justice and the Relief of Suffering, that was previously published in the Hastings Center report. So Jean, welcome. Thank you so much. We really are looking forward to your talk. Appreciate it.
Thank you, Julie. And hi to everybody. This is sort of the launch of this season's Ethics Grand Rounds and the giant experiment of Zoom Grand Rounds, which is not my favorite method of sharing and discussing things with you, but this is where we are in September of 2020. And we're going to have a wonderful experiment here, which is we're going to take a couple of polls of you folks. So don't let your keyboard wander away. David Weil has been good enough to attempt this kind of technology with us, and you'll get to see how it works, and so will I, as we go along. So I do have some objectives for this. We're going to look at both disease-altering new drugs and symptom management drugs and the challenges of those in this COVID pandemic. We're going to talk about justice issues, and then something about the contrast between curative care and palliative care, which is in tension but also complementary in the course of this pandemic. Just a reminder, this is something that is a little bit basic, but I wanted to stress the fact that the ethical framework in the midst of a pandemic is a little different from what you and I were raised with as healthcare professionals. Usually we deal with clinical ethical situations where we prioritize individuals, those people in front of us that we are caring for. We promise to be faithful to them, to relieve their suffering, and to respect their preferences. That's a duty of care. When we get in a pandemic situation or some other kind of a disaster, we have to switch gears so that we emphasize more prioritizing the community as a whole. And that's what we call public health ethics. And it's based on the underpinnings of the fact that there's a moral equality of all people, and that equity, fairness to the relative to the need, needs to be honored. And sometimes that means that prioritizing the individuals we're in front of may be a little bit lower on the hierarchy of triage than it would be if we were just dealing one-on-one with patients, because our goal is to promote safety and health and to be fair as we allocate limited resources. So this has been capsulized in the Hastings Center papers, as well as by others, including Matt Winia, who was a co-author with me on several of these papers, is the duty to plan. Now, the duty of plan today, September 10th, we are at, feels a little bit weird right now, but I want to warn you that this is the graph of the pandemic waves of the 1918 flu epidemic. So the pandemic came in waves, and actually you'll notice that the second wave of that pandemic was much worse than the first wave, actually. So even though we're in a lull, or because we're in a lull, our duty to plan almost becomes greater. And we need to think about who is responsible, federal, state, local, each institution, and what kind of planning should we do in what we now call sort of the contingent phase of taking care of our healthcare system. The contingent phase means, oh, some things are starting to get a little bit short. There isn't any decrement in care, but we may be jerry-rigging some things. We may be compensating. We may be opening floors of hospitals that weren't open before. We may be reusing PPE. We may be doing certain things to try to make sure that we don't hit what we would call, and what the state calls, crisis standards of care, when actually we hit the wall and say there isn't enough of something to go around, and we have to choose who gets a scarce resource. That's a situation we really don't want to get into, and that's why the contingent phase like we're in right now is so important in terms of a duty to plan. Just to remind you of some of the uniquenesses of this pandemic. Over the past several decades, every time there have been federal planning and state planning groups who've gotten together and thought about how to do this kind of planning. And every time there's a pandemic or a disaster or a 9/11 or a SARS-1 or Ebola, those plans get tweaked, and this pandemic is no different. It's a bit unique. For one thing, this is a graph from Colorado. It's about 3 weeks old right now. They haven't updated it. The gray bars here are our population by age groups, by decades. And you can see that although the 70 on up age group doesn't account for a large amount of the population, this is the bars of the percentage of the deaths that fall into each of those decades. So 2 or 3/4 of the deaths occur in that 70 on up age group. So that's one of the uniquenesses of this pandemic. It's unique in other ways. There is significant spread that occurs in infected but asymptomatic or pre-symptomatic individuals. You're reading about that in the paper the way I am, sort of with every passing day. But that makes contact tracing or quarantine pretty tricky because of that factor. There's also a wide variability of the disease, and that's why there's sometimes some problems with buy-in from people who have the disease. It's very mild, and they sort of shrug and say, well, I don't know what the big deal is. So this wide variability makes it hard for some people to take it seriously. The other thing that I think is most stunning about this is that rather than a single disaster, a 9/11, an earthquake, something like that, this pandemic has been waxing and waning in different geographic locations over time. And it's been, that has some pluses and that has some minuses. I mean, it's not like that we can choose it, but I'm seeing, I know, and hearing many stories of healthcare workers who are getting extremely fatigued. This is not like, okay, there's an earthquake, we're going to need to take care of people, or we're going to rush to Haiti for a month, we're going to pour out our soul for it, and then we're going to go back to life much more like usual. Whereas we're seeing 6 months, 7 months into this, that we're still putting huge stresses on the healthcare system. On the other hand, we also have a chance to learn from from the first surge and from other locations that got hit hard very early. I'm not going to go through all of this, but there's 2 interesting ways that I have learned a lot from the New York City experience. One is an article by Tia Powell called What Lessons Did We Learn? What Should We Have Done Different in New York City? That's in the American Journal of Bioethics, and she outlines some of these things here. She talks about the fact that everybody was focused on cure rather than thinking about the fact that there's some people who were sick who are not going to be cured, or who are in other institutions being sick. But the ones I want to highlight for today are the shortages in sedatives and pain medication. And if any of you listen to the podcast, The Daily, which comes out of the New York Times every day, there was a podcast from The Daily that talked about the problems of the differences between public and private hospitals in New York City, and the fact that private hospitals had more access to drug trials. They had different staffing ratios and equipment than the public hospitals. So some of this feeds into some of the problems and challenges that we have with medications. So first kind of medication that I wanted to talk about was the group that is COVID-specific disease-altering medications. It's sort of one of three groups. And in Colorado right now, there is a state advisory group that is advising the Governor's Council that is looking at each of the three of these different categories of medications that could become short and could need special allocation by people, by all of us. So the first one is COVID-specific disease-altering meds. I think these are the ones that actually make the headlines most of the time. The first one of these that we saw was Remdezavir, which turned out to not be quite as much of a miracle cure as we originally thought. And in fact, what it mostly does is shorten the time to recovery in some patients. But actually, in a way, it never became super short, but it did teach us some things. So here is a headline that came out of the first Remdezavir scramble. Whoops, sorry here. Which was talked about the fact that there was a lot of confusion about how should Remdezavir be distributed. The feds distributed some to hospitals, they bypassed states, they didn't give states criteria as to who should get it, who should be top priority. A lot because we weren't exactly sure who Remdezavir helped. And eventually Massachusetts became so confused by the whole thing that the hospitals actually got together among themselves and said, here, we're going to hand back whatever we've gotten mailed by the feds, delivered from them. We're going to give them to the state, and state, why don't you, in a more coherent fashion, figure out what the fairest way to distribute this is based on the people that are in various hospitals and with various symptom loads. So that was a good lesson in terms of, yikes, we need to start figuring about how we're going to allocate the medications. And so Remdezavir, which actually never got super short, has been a great practice model for the rest of us. And the big struggle is to say, what is a fair allocation scheme? Should we give a medication that's new, that's disease altering to the sickest people? Should we protect the youngest? Should we give this to what we call multiplier people or instrumental people? These are frontline workers who are taking care of COVID patients, but they're also essential workers who support them. Or should this be on a first come, first served basis? So here's your first contest. I'm going to tell you that 2 weeks ago, use your imagination, it doesn't take a whole lot of imagination, a new disease-altering that is called hydroxyporcelain. We have just adopted this name. It's for sick people on the ventilator with COVID-19. The pharmaceutical company is very convinced it's going to decrease time on the vent, may increase survival. Our hospital here received 50 doses, 47 doses they used in this first 2 weeks at the peak of the surge, and they now have just 3 treatment courses left. So I want to know what you would do in terms of who you would allocate these next 3 treatment courses left. So this is our first test of a poll. I'm going to have to unshare, and David is going to rule the world here. And that looks like, David, I'm not seeing, are other people seeing that they get a chance to vote? I'm seeing what the results are. But that may
Yeah,
be.
I see the vote.
Yeah,
You
Jean,
got-
we're seeing the.
Okay, so you're supposed to choose the 3 people you want to get. You only have 3 doses, 3 courses for this. I'm not seeing any of you choosing anything. Oh, okay, we got 1. There's hope here for you guys.
I'm trying to submit, but it's not taking it.
Have you scrolled down and done both polls?
Oh, there's a second poll here.
Ah, good. Thank you.
Sorry, you're right.
Can we only vote once?
Now you vote for 3 people and then you scroll down and then you think about what would happen if we did a lottery. David, that's part of this one, isn't it? Okay, we're getting
We're
there.
going to answer the second question at this point as well.
I think we have to, do we?
We do.
Before they can submit it? All right, we'll give it another few seconds. All right, let's see. Shall we stop? Let's see. Stop sharing. Poll closed. Okay, I just closed the poll on the 30% of you, the 30 of you that did not yet vote. All right. And can you see the results now, team?
I can.
Okay. All right. So let's see, what conclusions shall we make from this? You guys wanted the teacher and you guys wanted the housekeeper from the hospital to get this. I'm afraid that David put in this professor of emergency medicine. You guys were not particularly excited about having me get this. Let's see. And elderly patient or somebody who is very immune compromised. Okay, that's interesting. So David, can we go to the second poll here? So one of the ways people think, so let's see. David, do you know how we get to the second part of it? We're all learning. You have to realize this. This was a sort of a tricky one. It was a triple toe loop. David, do you have some results that you can share with us for the others?
When you display the poll, we can scroll down on the poll from our side so we can see it there.
Thank you very much, Brianna. All right. So now, one of the ways that allocation schemes have been thought about, particularly for disease-altering medications, would be, let's just have a lottery. Everybody gets dumped into the lottery and it's a random choice whether you're able to get it or not. There's a lot of fairness to that, actually. But there are people who say, you know something, I'm not sure that a straight lottery is really the best way to go, that there are some people who we should maybe give a leg up to. So I see that a lot of people thought that direct healthcare workers should get a leg up, and that other healthcare workers too, as well as essential workers, okay? But not people in hospice, although this was a negative part of this question. So we'll talk about that in a second. I'm gonna go back to my slides here. Share, there we go. All right. So, all right. So as people think about this allocation, just as you did right now, one of the first things that popped to mind was, let's go with a first come, first serve kind of thing. That's a not uncommon method of allocating certain things in society. If you're up there at the top of the queue, then you get it, and eventually we run out. But people have said, wait a minute, that is not really the most fair thing. In fact, New Jersey tried this first come, first serve with Remdezavir. And the problem is, hey, wait a minute, there's some people who are slow to get health care, who have poor health care access. They may be disabled. They may not come to the hospital until they're super sick. They may not trust the system. And so the question is, wait a minute, is this really the fairest thing? And that's one of the ways that people came to derive the thought of, well, let's think about a lottery. Is that the most fair thing? And the question is, in the interest of not just equality of access, but equity, should we give a leg up to some people? And the scoring systems right now that are being debated, you may hear across the country, and they do involve exactly what you guys were choosing, which is, should we give a little leg up to people who are caring for COVID patients? Should we give a leg up to the people who are supporting them? The lady who's cleaning the rooms, etc., or feeding people. But when you think about it, there are other essential workers also, in terms of the police and the fire and other essential workers who are at higher risk. The other thing that not a lot of, about a third of you, I think, were interested in was, should people who have historically had less access to health care, and so their social determinants have been at a disadvantage, should they get a bit of a leg up? And that is a big debate going on right now. In Pittsburgh, which has one of the allocation schemes that is being thought about here and other places in Colorado and elsewhere, they have developed what they call an area deprivation zone, which is some kind of score that you get depending on what zip code you live in, what part of town you live in, and that those people may get a bit of a leg up in terms of their prioritization in a lottery scheme. Clearly, that's something that people are starting to think of in terms of corrective justice, or in terms of not making the disparities in healthcare any worse than they are right now, certainly. So one of the questions is, should those in hospice receive decreased waiting? It sounded like people weren't particularly interested in pressing with that one. And is there anything different if the drug is really of unknown benefit? There are some corners of our population that would say, I do not want to be experimented on. You let somebody else figure out whether this is worthwhile first. And so there's some other considerations depending on how sure we are that such a medication is going to benefit people. So currently the thinking is, be sure that the allocation is based on the best evidence that we have at the moment. And as all of you have learned, that is a very dynamic thing. We're switching who we think might benefit from a drug on a pretty much regular basis. And as with ventilator triage, do not exclude people on the basis of non-medical criteria, such as race or ethnicity, age, disability, national origin, insurance status, sexual orientation, etc. Also, people have reminded us, and the people who are doing these allocation schemes say, hey, don't forget that just because somebody has a poor prognosis, don't exclude them from drug trials. Because frankly, they might be the ones that benefit. Until we know, they should be included in the lottery also. And then the other reminder is patients who receive medicines already approved So long-term medications should continue to receive them. And part of the duty to plan is the need to plan to support people who don't get enrolled. I'm sorry, the lottery has been enacted. You were not chosen to receive this. Here's the support and the commitment we do have for you. Okay, so let's switch gears a bit and talk about another medication. This medication just came up in the news in the last month or so, which is dexamethasone. It's interesting because not only is it felt to be a disease-altering medication, but it's also a common medication for symptoms and for a whole wide range of people. And there are already shortages that have been reported of at least parenteral dexamethasone, not actually the tablets. But hospital demand was up 600% in 1 week in June after the report came out that dexamethasone reduced mortality for seriously ill patients by 1/3. So it is the latest hot button medication in the press. Now, the World Health Organization last week said they recommend systemic corticosteroids for severe and critical COVID, and that it not be used to treat patients with milder COVID, as they may risk increased mortality. Remember, that's suppressing your immune system in some of these patients. So here's your next quiz poll, which is, you're a very sophisticated audience. I'm going to unshare, stop share. So you're a sophisticated audience. If you get COVID-19, you know what the WHO says, and you're on oxygen but not on the ventilator, would you want to have dexamethasone? David, I think there's a learning curve here. We're getting more participation in this one. Maybe it's less complicated. All right, well, that's pretty good participation here. Thank you, David. You're sharing the poll results. Okay, so a little over half of you would say no. I'm not going to take dexamethasone. I'm not sure what I'd say. It's such a benign drug. Once you get it out in the public, one of the points of this is to say that once it's in the press, once it's in the public domain, it's sometimes hard to say no. If I were sick myself, even if I didn't have critical COVID-19 pneumonia. So interesting. Okay, David, let's see. I need to share my screen again. Share. Ha. So who uses dexamethasone? That's one of the interesting challenges with this medication.
Could you put this into screen show mode?
David?
Could you put this into screen show mode, please? You know, the little screen icon at the bottom of your screen? I'm looking at all your slides and your notes.
Yes,
there you go.
There we go.
Thank you.
Thank you. See, this is why I pay him the big bucks. All right, so who uses dexamethasone? Well, according to WHO, non-critical ICU or critical ICU patients, non-critical, maybe. Almost half of you thought maybe. But there are other indications for parenteral dexamethasone, like asthma, some cancers as an antiemetic for chemotherapy, and some bad allergic reactions. There are some substitutes, but we need a coherent plan in order to figure out how we're going to allocate, how we're going to inventory dexamethasone, and then how we're going to allocate it to patients if a shortage does continue to happen. And it's likely to if we have another surge, given what the WHO has recommended. All right, so dexamethasone straddles sort of the issue of medication allocation. It's disease altering, but it's used for other things. What about the other category of symptom management medications? How does fairness play out when we're allocating symptom management medications? Why is that a big deal? Well, it's actually one of the things that in doing some state planning, we realized that this is a big problem, because as we think about ventilators and disease-altering medications, the criteria for allocating, if things get really scarce, is we try to save the most lives or the most life years, or somehow to help society the most we possibly can with saving lives. On the other hand, symptom management medications are also used by palliative care patients, patients who are not into disease-altering concerns. And in them, the idea that lives saved is sort of not part of the goals. What's more important is reducing suffering and giving the best symptom management. So the two of them are a little, not at odds, but are complementary. And it's harder to figure out how to allocate, how to inventory, and how to figure out what's going on with those meds. So here you are again. This is your third, going to be your third survey. The hospital pharmacy calls you. They're very short on IV morphine, and that actually has been happening. In fact, their supplier says there's a shortage throughout the region. So your hospital not only is an acute care hospital, it supports one subacute care facility and a hospice service. So who are you going to allocate the morphine to? We're going to do our third poll here. You're only allowed to choose 3 of these people to get morphine because it's in such shortage. All right, David, I think you've shared results. Thank you very much. All right. This is actually an impossible question, and you are forgiven for whatever you decide here. My point in putting this in here is primarily to show you that this is an impossible situation. To say that you're going to thumbs down 1 or 2 of these people or categories of people is just, it's inconceivable. It's beyond where we want to get our head wrapped around, I think. And it makes the point that we realized as we were doing planning for state allocation, it made us realize that we have got to figure out, particularly with these symptom management medications, how to avoid ever getting to a crisis standard where we have to limit allocation of these medicines. So in the 2012 Crisis Standards of Care by the Institutes of Medicine, it says, provision of palliative care in the context of a disaster with scarce resources can be considered a moral imperative of a human society. And I saw almost everybody saying that those people with chronic and severe diseases sort of feel like they're at the top of your list of people you'd want to take care of. But the problem with symptom management medications is really huge because the spectrum of people for whom they are indicated are enormous. Down at the bottom, the picture here is of what we call a comfort care kit. It's a kit that's used in hospice. Some of you may be familiar with it, that is dispensed by hospice providers to patients to help support symptoms in the middle of the night or for a couple of days until a provider can get to them or they can get to their medication. It includes morphine, it includes a lot of other things, and it's there to help the caregivers support a person who is in hospice. But all of these people need and deserve various medications, not just morphine, but sedatives for delirium and dementia, which it turns out in COVID time has been an important concerning symptom, even in the ICU, but for trouble breathing and people in the whole spectrum of sites where they're getting care. So what are we thinking about when we think about these symptom management medications? Well, people are thinking a whole lot about this. First of all would be to plan what are the essential medications? Everything from morphine to benzodiazepines, sedatives, albuterol for people with asthma. What should we call that core group of medications that we've got to be very vigilant about? And then how do we plan to inventory that? How do we talk to the wholesalers and prevent them from stockpiling, but also prevent them from giving it all away? How do you titrate that? There have been suggestions we should not be distributing more than 30 days to retail pharmacies. We should be expanding the capacity for mail order and home delivery of medications. And perhaps we should be relaxing refill criteria, which requires agreement with the insurance carriers so that people themselves can get 2 or 3 months worth of medication as opposed to the retail centers there. In New York City, it turned out that for comfort kits, for morphine, that the stocks of morphine in institutional pharmacies as opposed to retail pharmacies was much greater. And so they ended up making up comfort kits and having medical students actually deliver them to people's homes to assure that people in hospice had adequate pain relief and medications. The problem with the symptom management medications is that the supply is difficult to inventory. These medications exist in nursing homes and in retirement homes and in retail pharmacies. They are needed in homes, private homes, and in acute care hospitals. And because of that, the term that we call the burn rate is difficult to assess. That's how much of each of these meds do we use in normal times? How do we figure that out? And then how do we predict how much more we're going to need if we have a big surge? Because that's very hard to predict. So I'm going to leave you with 3 questions, and then we're going to open this to some discussion, I hope, which is conundra that we're starting to learn about as this pandemic evolves. One is the concept of excess mortality. Right now, the CDC is starting to publish how many deaths have happened that are in excess of what we directly attribute to COVID-19. And it turns out, and the last statistics were actually from early August, so they're a month in arrears right now, but there's over 200,000 excess deaths that have occurred across the country during the last 6 months, okay? And that's 60,000 more than the number of COVID deaths. So 60,000 people have died, not of COVID, but of something else. Is that because, as some people have found, people are not getting their medications filled? Is it because they aren't coming to the ER because they're afraid? Is it miscounts and mislabeling? I know that my colleagues at Denver Health say that in cardiology, they found double the number of at-home MIs during this time as they would see normally? Is that because people aren't refilling their meds? What part does, and what are some of the causes of that? It's going to take us a long time to flesh that out. But I think med scarcities and med reluctance may be part of it. Here's another ethical conundrum, which is the rise of what somebody on Marketplace yesterday called vaccine nationalization or nation support, which is that when we get a new medication, are we going to say, wait a minute, we need that all for us, and we need to take care of our citizens before we share that with the rest of the world? What is our obligation to the rest of the world versus to ourselves? This is a little bit of a disturbing headline to be seeing. Not that what the BMJ didn't say was, well, wait a minute, Remdezavir isn't all that great a drug, so maybe we're cool with that one. But what about the next one that works better? Are we going to hoard it all for ourselves, or how are we going to distribute that across the world? And then the next question, the last question I'll leave you with, that the ethics community is dealing with is, what kind of obligations do we have in terms of what we might call corrective justice? In the time of this pandemic, when we know that there are social determinants that are hugely at play in terms of who gets sick and how sick, what obligations do we have, and what can we do to not only make sure we don't widen the disparity gap, but should we try to close it? Should we go out, this is going to be a big question with vaccines, should we go out into communities of color and communities that are dense, and should we go out and make positive pitches for a vaccine instead of just saying, come on, we're open for business, come and get a vaccine? But the same thing's true for symptom management medications. Do we take the morphine? Do we take our hospice patients and say to their caregivers, here, let me help you do the best symptom relief that's possible, and actively offer medications to people instead of just accepting the fact that disparities exist and that people of color and people who are afraid to seek care in the healthcare system are just going to die more painful deaths? Or do we need to do something more active? So in conclusion, there's some challenges with both of these types of medication. For disease-altering medications, we've got the challenge that there's preemptive excitement in the media that sometimes distorts the information. We oftentimes don't know exactly whether this benefits the worst, sickest patients or least sick patients. Once the FDA gives emergency use authorization, we can't exactly study these medications because the people who get it it's not a random allocation. And one of the interesting things about the lottery system is that it actually ends up being a bit of an allocation system that's random and where we can actually study and learn more about the medication rather than having it under an EUA. And what would be the fair distribution and fair allocation? For the essential symptom management medications, what are our obligations to those who won't survive? What is our commitment to the non-COVID patients? How do we figure that out? Because it's such a scattered system in such a variety of settings. And when you think about it, just as you did with the third exercise, how do we avoid the degradation that comes when we actually hit a wall and we have a shortage and we have to make crisis choices? Because the bottom line, after we come out of this pandemic at some point, is what kind of allocation schemes and how will we distribute meds as well as other things that will help us come out of this, trusting that, you know, as a society, we feel like we did our best and we enhance trust rather than creating more walls. So I'm going to end there, and let's do some
Jean, thank you very much. Thank you very much for your, it's both compelling and provocative, and we appreciate the talk. For everyone, if you would go ahead and submit your questions or your comments through the chat feature, I will read those out and get those to Jean, and we will address those. I wanted to start with at least one question, which is in all of the different allocation considerations that are being considered around the country, where is the patient's voice in those?
That's a very good question. And it's been hard to figure out where the patient voice is. Now, the decisions ultimately are made by a governor's council in Colorado. We are lacking federal guidance on many of these things, in case somebody didn't notice. And in Colorado, there is a governor's emergency council, and there are advisory committees, including a very robust community advisory council for that sits and listens. We did crisis standards for palliative care and hospice and presented it to them, got some good questions from them. And so they're in it there. There's not a good structured, everybody tries to have a couple of citizen members on their committees doing these decisions and to make them transparent. So if you go to the CDPHE website, the Colorado Health Department website, you can read all of the allocation schemes that have been adopted so far. And that's mostly for ventilators and ICU beds. If we come to the point, which we have not yet, and only a couple states have, where we invoke crisis standards of care. But right now there's 3 committees who are trying to develop allocation schemes for these 3 different categories of medications. That's our big push right now, thinking ahead to vaccines a lot. And those will then be presented to the community. They will be open for comment and then adopted by the governor and available to everybody. And we're listening to other states, but the voice of the patients is hard to get in a meaningful sense, I think.
I think, you know, you're right. And there's sort of the policy level, but in clinical ethics, there's always well, what does the patient want? And, you know, the patient who wants absolutely everything despite the dismal outlook, or vice versa. And so the person who doesn't want some kind of intervention. So even if a policy states, a government policy states that they're within the allocation guidelines, or we all vote on it, and the person may say, well, no, actually, I don't want that. So I was just curious how that fits in.
So part of the crisis standards is the fact that these rules are transparent. They are very carefully crafted to not include biases as much as possible, which doesn't mean we didn't start with biases to begin with. There is an appeals process, and it's not the people at the bedside. Here's where that switch to public health ethics comes in. It's not the people at the bedside who are making decisions. It's a group of people overlying them who say, Julie, your patient is not eligible. We have patients who might benefit more, who are going to need to get the medication. And only if more becomes available will we have your patient do that, so that you can stay shoulder to shoulder with your patient. They do have an appeal mechanism, but it's mostly we've heard you and here, let us explain again.
Right. Thank you. Okay, from Sam Robin, a comment regarding opioid distribution. I think it's also important to point out you couldn't effectively support a patient on a ventilator without some type of opioid or sedation medication. This came up at 4:30 on a Friday afternoon a few months ago.
And that's right. It's one of the problems with symptom management medications is the wide distribution of sites. And yes, it's needed in the ICU. It's needed on the regular patient floor. It's needed for non-COVID patients. It's needed in long-term care facilities. And then it's needed at homes where people are in hospice. Which makes it super hard to inventory and then figure out how you're going to divide it. And it makes it really mandatory that you have careful inventorying and up supplying so that you don't run out. Now, we have pharmacists who will help us develop substitute medications, but Sam may be thinking about the fact that when we use sedating medications and we use second and third line ones, they're second and third line for a reason. And for instance, people have discovered that the second and third line delirium treatments for people in the ICU cause more delirium, or those sedating medicines cause more delirium than would the first line medication. So there's trade-offs that have to be balanced.
Right. Okay, a really helpful question from Amos Bailey. Do you have any thoughts on the ethical implications of the recent approval by the FDA of COVID recovery plasma and how that would impact trials of the intervention, which include placebo?
Well, that is the dilemma I think that we're all facing. I don't know whether Matt's on the line here, but this is a particular problem that he's working on with the newer drugs that are potential interventions. Once they get approved and widely in the press, and you stop doing randomized studies that help you learn more, it does tie your hands in terms of figuring out, because the people who demand it are not the same as the ones who don't, or the hospitals who have access to it are not the same necessarily as a hospital in Montrose that can't have access to it.
Mm-hmm. Okay, Jean, do you know anything about any duty to try laws that have been invoked around the country in terms of medications or treatments, since there have been a lot of efforts at innovating and trying various things?
I do not know. I will have to pass on that. Yeah, anybody here that can speak to it? We're in such a time when we're having to think of the whole community that, to me, duty to try, at least in relation to COVID altering medications, doesn't seem to make any sense or be able to be in play. And the rules for the duty to try laws that say that you have to be more than 50 miles away from a center that's using it, et cetera, would almost preclude thinking about it.
Right, right. I have one other question that has to do with the emergency kits or the essential medication planning that you were referring to. How would that work for people who have no resources at home or no resources? Are they just without?
They will probably end up having to come into the hospital and then maybe being placed in a long-term care situation. You're talking about people who are palliative care kind of patients or hospice type patients?
Palliative care type patients, yeah, or who need some kind of essential meds, but may not have the resources for that.
Resources in terms of money is something that seems to be nobody is paying attention to at the present time. There are a lot of people who either their spouse becomes sick, or they become too frail to be taken care of at home, or they can't get the medications, which I think is what you may be talking about, Julie. And they end up coming into the hospital and needing to be triaged either to a convalescent care unit or to find a bed in a long-term care unit. And that whole site and space issue is another one that's being planned for, sort of with a different group on the state level. But that's the way they're going to have to access meds unless they can get hooked up with a hospice doc or a provider to get prescriptions for those meds. And actually, one of the state initiatives is to put a list of those essential comfort care meds sort of up on the websites and try to teach primary care docs who may not deal with end of life on their own, usually, show them the kinds of prescriptions that need to be written to help caregivers. It's a little bit scary.
Yeah, definitely, definitely. Well, we will be addressing those kinds of issues, I think, and more. Any other questions people have, please submit those to the chat. And other than that, I do want to, we're about at time, and want to thank you, Jean, very much for this presentation, really very compelling and provocative and amazingly so real with what we're coping with these days. So I really appreciate that. And David, thank you for the help with the polling as well. The next Grand Rounds is going to be October 8th. It will also be virtual, and you will be getting an email announcement out about that. That will be Dr. Dan Matlock, who is worked very hard on putting together a decision aid that's being used in various places to get the patient's voice into triage decision making. So that will be a very nice follow-up to the community health and policy issues that we've been talking about today. So we will see you in another month for Dr. Dan Matlock. Again, Jean, thank you very, very much. Very helpful, and everyone be well. Bye-bye.